Hi everyone, this is Alex Chorley recording a lecture for the McMaster Emergency Medicine Academic Half Day in April of 2016. The topic today is fever in the returning traveler, which is an important one for us in emergency medicine. This patient presentation is often anxiety provoking because we don't deal with these tropical diseases very often, but I think it's important to remember that many returning travelers have neither a serious nor exotic illness. Often what they have is a URTI or a diarrheal illness, but we still need to rule out serious infections as well as protect the public from outbreak and begin the diagnostic process for our colleagues. We're going to go through an organized approach to febrile travelers, as well as talk about one of the most serious infections, malaria, and then go on to discuss dengue fever, chikungunya, Zika virus, and typhoid fever. This is a table that I ripped out of Tintinelli's, and it's helpful at highlighting that common things are indeed common. And as you can see here, travelers are more likely to come back with a routine infection like a diarrheal illness or an upper respiratory illness than they are to come back with plague or Chagas disease. That being said, you still are at a moderate risk of contracting things like dengue fever, malaria, and chikungunya. An organized approach to fever in the returning traveler involves number 1, screening, 2, a thorough history, 3, a focused physical exam, and 4, appropriate investigations. Screening is crucial when it comes to the febrile returning traveler because it allows us to isolate people appropriately and use personal protective equipment early on in their evaluation. And we're already familiar with some techniques for this. We've seen checkpoints at the entrances to weight rooms before. We've all seen the FRI, the febrile respiratory illness screening sheet attached to the triage nurse's note. And this is an important way to capture people who may have traveled to high-risk areas. Recently, people have been on alert about the Middle East respiratory syndrome, which is the map that's highlighted here. The other kind of outbreak that's been in the news a lot in the last year or so has been Ebola. And so we've been asking targeted questions to try and prevent any sort of outbreak of those illnesses reaching us here. The best way to approach the history is to break it into 3 parts: the pre-travel information, the travel itinerary itself, and potential exposures abroad. The pre-travel information is important because you want to know if they have any pre-existing medical conditions that could put them at risk for severe disease, and that includes any of the risk factors that I've listed here on the slide. You want to know if they saw a travel specialist in consultation before departure, and did they receive any medications to self-treat while they're away, and that includes things like antibiotics. You want to know if they received any sort of vaccines, because proper vaccination will essentially rule out things like hepatitis A and B, as well as yellow fever. Another extremely important aspect is to know about chemoprophylaxis, and that's things like taking antimalarial, like Malarone, because that will significantly reduce your chances of contracting malaria. It's important to know what type they were on and whether they were compliant, especially because some regimens require you to continue the medication for up to 1 month after you come back from abroad. The important point here is that prophylaxis can reduce your chances of contracting disease, but actually doesn't rule it out. I know it's difficult to think about this outside the realm of pediatric emergency medicine, but it's important to ask about their immunization history in general because you want to know if they received full vaccination courses for things like polio and diphtheria, because that will significantly affect things on your differential. Knowing the patient's nation of birth is important because they may have some immunity from living in endemic areas, but that immunity typically starts to wane after about 6 months or so of living away. So if they were born somewhere else, you want to know how long they've been living in Canada or elsewhere. I've interspersed some take-home points throughout the talk, and so the take-home point for this section is that chemoprophylaxis does not exclude infection. So it's really important to continue to work people up for things like malaria, even if they've been on chemoprophylaxis while they've been away. The next section of your history taking will involve their travel itinerary, and this is an important section to obtain really detailed information about where and when they traveled. This includes exact departure and arrival times, and the last 3 to 5 years may eventually end up being relevant, even if that's not immediately apparent. It's important to know the season of travel. Was it the dry season, the monsoon season, and were there any stopovers or locations of transit? It's important to know the general purpose of their travel because different activities are going to have different risk profiles. Business in urban centers is entirely different than visiting rural areas, especially if the patient is traveling there for adventure tourism like spelunking, um, or if they're doing something else like providing medical care for displaced populations, because these are um, activities of much higher risk. You want to ask about where they were staying and the location of those lodgings, and whether or not there were bed nets and screened windows, as well as thatched roofs. You want to know who the patient was in contact with and how the health was of those individuals. Were they visiting or staying with relatives? Because that is a much higher risk exposure because you're more likely to eat the local foods and drink the local water than you are if you are staying in a hotel in a city. You also want to ask about the health status of any fellow travelers that were abroad with them because they could have similar infections to what your patient is presenting with. After you get a detailed history about what their travel itinerary was, you want to ask them about any specific exposures because these individual exposures will put them at risk for certain things. The first and important one to ask about is exposure to any drug use, specifically opioids and intravenous drugs. You want to take a detailed sexual history, including any high-risk contacts. Then that includes unprotected sex with anyone, any contact at all with commercial sex workers, or sexual contact in areas with a high prevalence of HIV. Although that picture of beef carpaccio looks delicious, it's important to realize that it represents a high-risk food exposure. That list includes things like wild game, raw or undercooked meat and fish, unpasteurized dairy, food from street vendors, as well as natural sources of water and salads because they often have been washed in those natural sources of water. Environmental exposures are also important, so you want to ask about swimming in fresh water versus salt water, any sort of hiking or trekking in the jungle or forest. If they did any digging, they were in contact with any soil, and that includes open-toed shoes or barefoot. You should ask your patient if there were any exposures to animals, and that includes things like dogs, birds, and rodents. Many of my friends learned the hard way that jogging in developing countries is not advisable as there are lots of stray dogs and they will absolutely chase you. Rabies is also much more prevalent in these countries, so it's something to watch out for and think of when you see these patients. You want to know if they were bitten by any insects or they received any animal bites. You want to ask if there's any assault or trauma in general, and were there any injuries that required medical care. If they did contact medical care in a foreign country, you want to know what kind of medications they received or what kind of procedures happened. Did they receive any dental procedures? And then you want to ask specifically about anything like tattooing and body piercing because those are high risk activities as well. I won't torture you guys by going through this table, but it's from Tintinelli and contains the possible infections that occur from specific contacts or exposures. So there's some pretty useful information in there, so please use it as a reference. And that's continued on this table as well. So if someone gives you some specifics, like I was bitten by sand fleas, you can think about cool diseases like leishmaniasis. After you've taken a very detailed history, you want to move on to a thorough examination, and that's going to include a standard examination that you would use for any febrile patient, and you want to target that towards their symptoms. In addition, in a febrile returning traveler, you want to make sure you consider their neurologic status, as there's always a potential for cerebral malaria, encephalitis, and meningitis. You want to do a thorough head and neck exam looking for any lymphadenopathy or scleral icterus. Make sure you examine the abdomen looking for any hepatosplenomegaly or focal abdominal pain. And finally, you should do a thorough search for rashes, and you're looking for any sort of rash, but especially things like petechiae. This is another useful table from Tintinelli that highlights specific physical exam findings you can use to hone your differential. For instance, you'll notice that if a patient presents with lymphadenopathy, malaria isn't really on the differential for that. So worth taking a look at this, and it gives you a starting place at least when you find some key exam findings. After your exam, you want to move on to investigations, and those will include your standard workup for a febrile patient when you're looking for an infectious source. Specific things you want to remember for the febrile returning traveler is the stool culture and O&P if you have any sort of GI symptoms. Remember that in your CBC with differential, an absolute eosinophil count of greater than 500 is indicative of parasitic disease caused by worms, so that could be useful information as well. And then you want to order things as needed, such as a chest x-ray. There are some specific investigations pertinent to the febrile returning traveler, and those include things like ordering a thin and thick smear for malaria. And if they get admitted, that's something you'll want to do on a fairly regular basis for the first part of their admission. You can also get rapid antigen tests for malaria, and we'll talk a bit more about both of these things later on. You can also get specific tests as indicated, and that includes serology for things like HIV, syphilis, as well as specific arboviruses or rickettsia. This is a fairly simplified differential for fever in the returning traveler, but these are the most common causes, and so we focused on many of these things today. You'll see that important things like malaria are up there, and fever in the returning traveler is malaria until proven otherwise. But you can also see that there are many common causes listed, such as UTI, pneumonia, mono, and so it's important to keep these things in mind as well when you're working at the patient. My second take-home point is that fever in the returning traveler is malaria until proven otherwise, so make sure you're ordering those thin and thick smears. And that provides us an excellent segue into our first disease, which is, of course, malaria. Malaria is a protozoan disease caused by Plasmodium species, and they're carried by the vector, which is the Anopheles mosquito. But malaria can also be transmitted by transfusion of infected blood, needle stick injuries, or transplacentally. It's important to note that the exoerythrocytic phase is absent in these cases, so there are no hypnozoites and no relapsing courses, and we'll talk a bit more about that later on. Malaria is a really important disease because 55% of the world is exposed to it, and there are hundreds of millions of cases every year. The vast majority of deaths are from the Plasmodium falciparum species, but two other species, Vivax and Noelzi, can be fatal. There are unfortunately many obstacles to reducing malaria or eradicating it, and those include things like war, poverty, the capacity of the mosquito vector for adaptation, which includes to insecticide and temperatures, as well as anti-malarial resistance in the Plasmodium species themselves. The majority of infections actually occur in children who get considerable immunity as carriers. They often have what we call asymptomatic parasitemia, which is a malaria infection. And when they get illness due to malaria, which we would call malarial disease, it is in fact typically mild. This is a map of countries with malaria risk, and as you'll see, it includes the tropics and subtropics. Important to note that it's below 1,500 meters, as the vector would not be a risk up in those areas. You'll also note that it doesn't include the Mediterranean or the US and Australia, so there's not any risk of malaria in those areas specifically. The risk of contracting malaria actually varies between different areas, and the vast majority of cases that occurred in the US from returning travelers were from travelers who traveled to Africa, despite the high numbers also visiting places like South America and Asia. So the 5 species of malaria are the Plasmodium falciparum, Vivax, Ovale, malariae, and Noelzi, which is a more recently discovered species. Of these species, falciparum is the most concerning, as it will have the highest chance of mortality. Any infection of this species in a non-immune host is essentially a medical emergency, because there's a 5 to 30% risk of death at the severe stage of illness, even after treatment is started. It's more prevalent in Africa as well as Haiti and New Guinea. There's a lot of resistance, unfortunately, in the falciparum species, and that includes to things like chloroquine and some resistance to quinine and mefloquine, especially if it originated in Southeast Asia. P. vivax and P. noelzi have also known to be fatal, but these infections are generally less severe than falciparum. Important notes about Vivax and Ovale include the potential for relapsing courses of the malarial disease if extra steps aren't taken in eradicating them completely from the host. And we'll talk about the pathophysiology of that in just a sec. This is a chart that I have almost entirely repurposed from the CDC because it had a lot of painful text on it. But so I've tried to narrow it down to the bare bones. The cycle starts with transmission by a bite of the female Anopheles mosquito, which you can see here, which needs a blood meal every 3 or 4 days. Plasmodial sporozoites are essentially then injected into the host bloodstream where they find the liver parenchymal cells and it invades those cells within hours. It then undergoes asexual reproduction, which is called the exoerythrocytic stage, which I've handily labeled as the liver stage here. Thousands of daughter merozoites are formed within the hepatocyte, which is called the amplification cycle. And then the cell ruptures and the merozoites enter the circulation and invade erythrocytes, which begins the erythrocytic stage. It's important to note that in PVVAX and PO Valley infections, some of the intrahepatic forms are not released but actually stay dormant as hypnozoites, which can then reactivate after months or years to cause clinical relapses. Once the merozoites are in the red blood cells, they don't reinvade the liver. They mature within the cell and enlarge to form a score of daughter merozoites, which eventually form something called a schizont. Eventually, the cell lyses again, more merozoites are released, and it invades other red blood cells, and the cycle continues. Portions of these merozoites go on to develop into sexual forms called gametocytes, and those are ingested by a mosquito feeding on this malarial infected human. And then male and female gametocytes undergo sexual reproduction within the mosquito's gut and migrate as infective sporozoites into the salivary glands, where they go on to infect a new host when that mosquito bites someone who isn't infected. It's important to note at environmental temperatures below 15 degrees, the cycle does not complete before the death of the mosquito, and therefore no transmission can occur. And so in climates where there is temperatures lower than 15 degrees, that is protective against malaria. The incubation period for malaria is days to weeks, and I've thrown an average up there, which is about 8 to 25 days, but will vary by species. It's important to know that incomplete chemoprophylaxis or partial immunity can actually prolong the incubation period for months and even years. Patients begin to show symptoms when the schizont RBCs lyse and release more merozoites into the bloodstream to infect more red blood cells. Fever actually slows down the rate of schizont formation, so early stage parasites will catch up with later stages, and the ruptures and therefore the fevers become more synchronous and periodic. It's important to know that this periodicity rarely develops when malaria is treated quickly and with appropriate medications. The top graph on the right there shows the periodic fevers for Plasmodium vivax, which will spike a fever every 2 days or so. And the second graph shows the timeline for Plasmodium malariae, which is every 3 days. Your third graph is falciparum, which shows that it's actually quite irregular. And then towards the end, you'll see the influence of successful treatment of the disease. The classic triad for malaria is fever, splenomegaly, and thrombocytopenia. And as usual, this classic triad rarely occurs in real life. Uncomplicated malaria will typically involve a viral prodrome, including things like malaise, myalgias, headache, chills, and often can be mistaken for sepsis or even hepatitis. Occasionally, the patient will get chest pain, a cough, or even abdominal pain, and this typically progresses to a high-grade fever, chills, nausea, weakness. The fever then abates hours later and leaves the patient exhausted and diaphoretic. On exam, you'll often find tachycardia, tachypnea, splenomegaly, as well as potentially hepatomegaly. Things that aren't typical of malaria include lymphadenopathy, a macular papular, or petechial rash. And that brings me to my next take-home point. So when you see a rash or lymphadenopathy in a febrile returning traveler, make sure you expand your differential because this is very atypical for malaria. Patients with malarial disease are often broken down into those with either uncomplicated disease or severe malaria. Those with severe malaria are often infected with falciparum, and it causes these severe symptoms due to the high parasite burden as well as the sequestration, that can occur with this specific species. Anemia can develop rapidly in these patients due to the high number of red blood cells that are lysed, as well as the fact that the lifespan of uninfected RBCs is reduced and bone marrow production of new red blood cells is suppressed in this infection. Falciparum also transports proteins to the surface of the red blood cell that adhere to endothelial cells, causing sequestration of mature parasites in the microvasculature of many tissues and organs. And this is enhanced by the impaired deformability of the infected RBCs. This sequestration benefits the parasite by keeping it away from the spleen, and as a consequence, the host has impaired perfusion and metabolic deprivation, leading to severe acidosis and severe anemia. The sequestration also accounts for the low number of parasites that are observed on the peripheral smears of patients with falciparum infections. The symptoms of severe malaria are listed on the right, and it's important to remember that this includes cerebral malaria. If cerebral malaria is suspected, we have to rule out meningitis and encephalitis, and the opening pressure of the LP will often be raised. The CSF is typically normal in appearance and on routine tests, and these patients may also have some retinopathy if you are lucky enough to see into the back of their eye. Very young, the elderly, and pregnant women are at the greatest risk of complications from falciparum infections. Other risk factors include immunocompromise, asplenia, failure to take appropriate chemoprophylaxis, and refusal or delay in seeking medical care, as well as late or erroneous diagnosis. The major complications that are often seen include massive splenomegaly leading to hypersplenism, glomerulonephritis leading to nephrotic syndrome, as well as thrombocytopenia. The diagnosis of malaria is made by a history of potential exposure, appropriate signs and symptoms, and then a competent microscopic examination of a well-prepared thick and thin blood smear. When they look at the blood smear, they ask 3 questions. The first being, is there evidence of malaria? The second, if there is evidence of malaria, what's the density of parasitemia? And third, what species is responsible for the infection, and is falciparum present? The parasite burden is rarely greater than 4% in infections with non-falciparum species. Another important to note on this is that P. noelsi is often misdiagnosed as P. malariae because they look identical in blood smear. You need to get a PCR analysis for differentiation. And this is clinically relevant to us because noelsi is much more aggressive, so we should assume that this is the infection a patient has if they are coming from Southeast Asia and have been diagnosed with malaria from a malaria species. This is a table that I distilled down from a much larger table in Tintinelli, but I think it highlights the key features here. And so a good way to break it down is this an uncomplicated falciparum infection? Is this an uncomplicated infection with a different species? Or is this a complicated or severe infection? And if it's falciparum, they always need to be admitted because the risk of moving on to a severe infection is quite high. Obviously, if it's a complicated or severe infection, they need to be in the ICU because these patients can be quite sick. But most other uncomplicated malarial infections can be managed as an outpatient with good follow-up. In the uncomplicated falciparum infection, you want to get them started on oral antimalarials if they can take oral medication. And the first choice is, and I apologize for this pronunciation, but artemisinin containing combination therapies. And these are the drug of choice as outlined by the World Health Organization. An example is listed there, and you would have to talk to the pharmacist for more details about this medication because I certainly have never seen it. Alternatives that we may have heard of more frequently are quinine medications in combination with either doxycycline or clindamycin. And the Center for Disease Control in the US says that chloroquine is actually okay if the falciparum infection is from an area of low resistance like Central America. You want to check these patients daily for parasite density and their hemoglobin. In uncomplicated infections from other species, You don't need to admit in most cases unless it's P no LC, which we talked about previously. The treatment is outpatient chloroquine tabs, or again, the artemisinin combo. An important note is that if this is a PVVAX or ovale infection, they need additional treatment to eradicate the hypnozoites that can live in the liver and cause those relapsing courses that we talked about. And these additional treatments can be given after recovery from the initial illness and include things like primaquine, but just be cautious in any patients with G6PD. In severe or complicated malaria, as we talked about before, it's often falciparum, and so these guys need to go into the ICU for frequent monitoring, intense supportive care, including fluids, glucose management, and potential blood transfusions and management of DIC. Often they will need to be intubated for ARDS and treated for shock, and empiric antibiotics are recommended as co-infection can't truly be ruled out in this situation. These are patients that need to receive IV antimalarials, and that includes things like quinidine with a loading dose and then infusion, plus doxycycline or clindamycin IV. As an alternative to quinidine, you can get special access to something called artesunate from the CDC, but good luck with that. These patients need to be on IV antimalarials for at least 24 hours and up to 7 days before switching to an oral treatment course. In all patients with malaria, you should start treating them before lab confirmation because the initial smear is often negative. The parasite load should decrease rapidly over the first few days, and even faster if the medication contains the artemisinin. Sorry, I cannot pronounce that drug. So my next take-home point is that Plasmodium falciparum infections are essentially a life-threatening emergency in any non-immune host and can often require intensive care and IV antimalarials. So we've covered malaria, and now it's time to move on to my favorite kind of viruses, flaviviruses. What are flaviviruses, you ask? I've listed some here. This is not an exhaustive list, but we're going to talk about some of these ones since they are important in the febrile returning traveler. First up is dengue fever, and this is the second most serious tropical disease after malaria. As I alluded to with that cool graphic, it is a flavivirus, and it's also called an arbovirus because it's spread by arthropods as well. So the vector is a mosquito, but in this case it's the Aedes aegypti mosquito, which occurs in urban as well as rural environments. And this type of mosquito is actually day biting as well, so it's a bit more aggressive. Transmission can occur also through transfusion of infected blood, transplant of infected organs, a needle stick injury, or vertical transmission from mother and fetus. Dengue infection is caused by any one of 4 related dengue virus serotypes, 1 through 4, and it can actually be contracted multiple times since the 4 strains offer, unfortunately, no cross-protective immunization. This is a bit of a cool map, and you can access this on the CDC website if you look up dengue fever, and it's a collaboration with healthmap.org, and it shows the case reports of dengue over the past 3 months. And again, you can see that this is a disease that's confined to the tropics and the subtropics, with a prevalence for Central and South America, Africa, and Asia, as well as the Indian subcontinent. I apologize for the poor quality of this projection, but I ripped it off the CDC website as well. And I think it's a great way to highlight the different classifications of a dengue virus infection. As you'll see up here, the majority, or sorry, not the majority, but about 50% of these infections will actually be asymptomatic. Those who are symptomatic will typically present in one of 3 ways, either as a non-specific febrile illness, which is often what happens in young children or patients experiencing their first infection. And in this case, unless serology is done, dengue is not going to be diagnosed because this is going to look like any other viral syndrome. And the other 2 ways it presents are as dengue fever or a dengue hemorrhagic fever, and we'll talk a bit more about those in just a few seconds. It's important to know that any one of the serotypes can produce the full spectrum of illness and severity, and it's very challenging to predict those who are going to progress to the more severe dengue hemorrhagic fever or dengue shock syndrome. So first, let's talk about classic dengue fever. And patients that develop this fever with or without hemorrhage are typically older children and adults. The incubation period is about 4 to 7 days, and they're often going to present with viral symptoms, and that's our usual things like headache, myalgias. Conjunctival injection is rare but can occur, as well as retroorbital pain. The patients then defervesce and can develop a fine, pale, morbilliform rash. And if you had to rack your brain for what that looks like, don't worry, so did I. So I looked it up, and it's that confluent rash that I posted there that looks a little bit like measles. And that'll often start on the trunk and then progress to the extremities and face. These patients can also get petechial hemorrhages and may have other hemorrhagic manifestations in this stage, but these are often minor and can include things like epistaxis, easy bruising, or a positive tourniquet sign. Overall, it's an uncomfortable illness, but fairly benign and has a self-limited course. Testing can confirm it in retrospect, but is often only available after the patient has recovered, and so treatment for this is essentially just supportive. My key take-home point here is that because of the incubation period, if the fever has occurred greater than 7 days post potential exposure, so say the patient has been home for 8 days and has now just become febrile, it cannot be dengue fever. So next, let's talk about the more severe manifestation of this illness, which is dengue hemorrhagic fever or plasma leak syndrome. And that can occur without shock or with shock, which would be called dengue shock syndrome. And again, I apologize for this poorly projected graphic, but I think that its progression here helps illustrate the course of this part of the illness. Dengue hemorrhagic fever can be distinguished from dengue fever by its 3 distinct clinical phases, and early recognition of this phase of this manifestation is crucial because it's very aggressive and early supportive care is required. So the first phase is the febrile phase, which lasts about 2 to 7 days and occurs much like typical dengue fever. So you get the high fevers, they can get dehydrated from decreased PO intake, sweating, lots of emesis, and they can even get convulsions from the high fever, which is where the term breakbone fever comes from. They may also have hepatomegaly with some jaundice and minor bleeding manifestations at this stage, just like in dengue fever. The viremia is typically highest after about 3 or 4 days, and then undetectable after the few days following that, which you'll finally see the dengue antibodies, which are IgM, increase as the fever abates. There are some warning signs that they may shift from the febrile phase into the plasma leak phase, and that includes defervescence, thrombocytopenia, leukopenia, and increased hematocrit from a fluid shift. So the second phase, the plasma leak phase, lasts about 24 to 48 hours, and that is sudden onset with varying degrees of plasma leak into the pleural and abdominal cavities. These can have severe complications, including hemorrhage or shock because of that severe plasma leak. They can also get metabolic abnormalities like hypoglycemia, electrolyte disturbances, metabolic acidosis, and coagulopathy, which can lead to intracranial bleeding and massive GI bleeding. These patients can also go on to have fulminant hepatic failure. They then move on to the reabsorption phase, which lasts about 2 to 4 days. And during this phase, the plasma leak stops and they start getting reabsorption of all that extravasated plasma and fluids. And so you have to be cautious if you're dealing with this patient potentially in the ICU that you don't volume overload them by continuously volume resuscitating them when they've actually stopped leaking. And so the management of dengue hemorrhagic fever really is early recognition with supportive care. And they're going to need a lot of IV fluids and make sure you're only giving them Tylenol because you're going to want to stay away from the ASA and NSAIDs due to bleeding risks. You're going to want to manage the hemorrhage and then consider transfusing them blood products as needed. And then just keep an eye out for the end of that critical plasma leak phase, which can be heralded by the normalization of vital signs, the return of an appetite, and a convalescent rash of dengue, which again is a confluent petechial rash with small round islands of unaffected skin. My take-home point for dengue fever is that early recognition and supportive care are the cornerstones of management of this illness. The next flavivirus we're going to talk about is chikungunya, And this is a disease that gets mentioned a lot and has a really cool name. So I thought we should talk about it a little bit as well. It's transmitted to humans through the bite of the Aedes aegypti mosquito as well, and humans are its primary host during epidemic periods. Bloodborne transmission is possible again through things like needle stick, and there's rare incidences of vertical transmission. Um, and the transmission from human to mosquito is highest when the patient is highly viremic during the first week of illness. This is a map showing areas where chikungunya cases have been reported, and you can see again that this disease is mostly confined to the tropics and subtropics. The incubation period is about 3 to 7 days, and the majority of patients that actually contract this disease do become symptomatic. And it typically begins with acute onset of fever, and that's typically a high fever in the 39 range, as well as polyarthralgia. The joint symptoms are typically bilateral and symmetric, as well as severe and debilitating. And the viral symptoms that come along with this kind of illness are the same as before. They can get lots of different lab abnormalities, and those are listed here. And most of these symptoms and abnormalities are going to resolve in about 7 to 10 days. These are some rare complications of chikungunya. And again, those at high risk are the very young, the very old, which they listed in this article as over 65, and patients with significant comorbidities, including things like hypertension, diabetes, and cardiovascular disease. Some patients may end up with persistent rheumatologic disease as well after they've recovered from the initial viral illness. The diagnosis is mostly made by clinical symptoms with a possible history of exposure, but you can confirm it with viral serology as needed, and the treatment really is only supportive care in this case. It's important to know that this is a reportable disease in the US and so likely in Canada as well. Make sure you're treating them with lots of fluids, NSAIDs for the pain and the fever. If they have persistent joint pain, they may need more long-term NSAID therapy or potentially steroids or physio. An important note, if this does come to your practice area, that people infected with chikungunya should be protected from further mosquito exposure in the first week of their illness to prevent local transmission, since that's when they have the highest viremia. You should base your differential diagnosis on their travel history as well as potential exposures. But remember, dengue and malaria are definitely on there, as they are both transmitted by mosquitoes and often will have similar features. My take-home point here is that if you have a patient returning from abroad with acute onset of fever and joint pain, definitely consider chikungunya. And even if that's just that you get to say the name in your differential. Next up, we're going to talk about Zika virus, because this has had a lot of airtime in the news lately. It's a single-stranded RNA virus, also from the flavivirus genus, also transmitted by the Aedes mosquito, which we mentioned before are aggressive daytime biters indoors or out. Non-human and human primates are the main reservoir of this. There have also been cases documented of perinatal transmission, possible sexual transmission, as well as transfusion transmission in infected blood. The majority of patients that contract Zika virus are asymptomatic, but if they do come down with a fever, again, they get those viral symptoms, and these can include rash, arthralgias, and conjunctivitis. There have been case reports of Guillain-Barré syndrome occurring with Zika virus infection, and the main concern and why it's received so much play in the news is because infection during pregnancy can actually lead to microcephaly in infants. Severe disease is fairly uncommon, fatality is quite low, and clinical illness is usually mild with symptoms lasting days to weeks. The diagnosis and treatment is essentially the same as for chikungunya. You're diagnosing them based on their symptoms and exposure. You can use serology to confirm if you need to, and then it's all about supportive care with analgesia, fluids, and rest. And again, you're going to want to protect them from further mosquito exposure to prevent local transmission. So you might want to hide these guys in hospital for at least a week. Last but certainly not least, we're going to talk about typhoid, which is also known as enteric fever and is also a life-threatening illness. 21 million people are affected with typhoid every year, so this is an important one, and it definitely occurs more often in the developing world. So as a quick overview, typhoid is caused by Salmonella typhi, and you can get paratyphoid, a similar illness, from Salmonella paratyphi. Once malaria is excluded, typhoid is the second most common cause of a febrile illness lasting more than 10 days. And vaccination can help protect you against this before travel, but it's important to remember that protection wanes over time, and so people need boosters frequently. If untreated, the mortality for typhoid is about 10 to 15%, and that's mostly in young children. Remember that the vaccine should be done at least 1 to 2 weeks before travel. Transmission is from food contaminated in a dose-related fashion with feces or urine from infected cases or from healthy disease carriers. The incubation time is about 1 to 3 weeks, and the way it works is that bacteria essentially adhere to the small bowel and invade your lymphoid tissue. This causes gut inflammation, necrosis, and ulceration, and it can then disseminate via the lymphatics into bone marrow, gallbladder, and spleen. This map is out of the Lancet, and again, you can see this disease is mostly in the tropics, mostly in the developing world, largely in Africa and in the Indian subcontinent and Southeast Asia. Again, you're going to get fever and viral symptoms, including high fever, chills, cough, abdominal pain, myalgias, constipation, as well as prostration. So these patients can be just really knocked flat. They also can present with diarrhea and vomiting, as well as meningeal signs. A classic sign described is that bradycardia occurs relative to their fever, so their heart rate isn't what you expect for how high their fever is, but it should be noted that this sign is neither sensitive nor specific. They may develop a pale red macular rash after about a few days, which are called rose spots. In the fair skin, you can see this pretty quickly, but in anyone who's a bit more dark-skinned, it's going to be really tough to pick out this rash. These patients can also develop splenomegaly, and the differential is similar to what we've discussed previously, but you want to consider things like malaria, typhus, viral hepatitis, amoebic liver abscesses, as well as infective enteritis. In terms of their labs, they may have things like leukopenia, elevated LFTs, and complications can include ulceration in the bowels, anemia, DIC, pneumonia, meningitis, and myocarditis. So this can be a pretty nasty disease. Typhoid can be diagnosed by cultures of the blood, urine, or stool, typically during the second week of infection, or by a rapid antigen test. Bone marrow culture is the most sensitive, but I think a bit more inconvenient to perform. And IDing the organism is still possible after you've already treated them with antibiotics. The treatment consists of things like fluoroquinolones or cephalosporins and azithromycin as well. And the duration of treatment depends on the severity of the illness. Cautious note, if the patient is coming from India or Southeast Asia, there may be a resistance to fluoroquinolones, so you may want to consider one of your other options. And if typhoid meningitis is suspected, they need a course of dexamethasone as well. Otherwise, it's mostly supportive care with IV rehydration and blood transfusion, especially if needed from extreme GI losses. So my take-home point for typhoid is that after malaria, typhoid is the most common cause of fever lasting for greater than 10 days. So it's something that you should usually put in your differential in the febrile returning traveler. So to sum things up, make sure you have an organized approach to the fever in the returning traveler, and you take a very thorough travel history, because that's going to really help you form your differential diagnosis. Always remember that fever in the returning traveler is malaria until proven otherwise, so that's always got to be on your differential. Make sure you get those thin and thick smears. Falciparum infection can be a life-threatening emergency, especially in non-immune hosts, so these patients always need to be admitted. Fever graded that occurs greater than 7 days post-exposure is not dengue, as it does not fit with the incubation period of that disease. If your patient comes in with fever and joint pain, think about chikungunya in addition to all of your other things you're going to look for. And then remember that typhoid is the second most common cause of fever lasting greater than 10 days in the returning traveler. These are some of the resources I used when putting together this talk. The CDC website in particular is a treasure trove of useful information, both for patients and for clinicians, so I advise you guys to check it out. And the EM Cases podcast on the subject was also very helpful. Thanks for your attention, guys, and I hope that this lecture was useful.